Uh, it's always a pleasure and honor. Kalyan is our boss. He leads the organization and IAG, and all of us know what IAG is today because of stalwarts like Kalyan. And now he's going to be the next vice president. So I don't know where. I mean, whether I'm wondering whether he'll be vice president first or a minister or an MLA first.
I want to see him as minister. I told
First
him.
as ministers.
No, and a minister is useful for us, no? OBGYN minister.
So we don't grow when things are easy. We grow when we face challenges. Thank you, chairpersons, and thank you, Kalyan, Monica, Madam Srikhande, for inviting me. Suchitra, it's always been a pleasure. One of the dearest friends that we have. When I passed out in 92, we would say baby should be healthy. In the millennium, we said mother should be healthy. Today, we are saying that the woman should be healthy, and only if a woman is healthy, she will become a healthy mother and give a healthy baby. As of now, I'm sitting on two patients, one with congenital pulmonary stenosis, severe, and a mitral stenosis, both who are about 28 to 30 weeks pregnant. So we deal with cardiac disease very, very often at Fortis Hospital. There are a couple of things that the woman needs to understand, and fortunately, a lot of women are coming to us for pre-pregnancy counseling. A simple story, I always put a stethoscope on the heart of the patient when I see a gynec and an obs patient. About 6 months back, an ICU nurse came to me with a positive pregnancy test and a beta HCG. She was an ICU nurse at Fortis Hospital, and when I put the stethoscope on the heart, I could hear a mid-diastolic murmur. We are not from the echo age, we are from the stethoscope age. And I told her there is definitely a rheumatic heart. She went up and she did an echo, and we realized that she had mitral stenosis. And it was a tight mitral stenosis of less than 1 centimeter, and we had to convince her to get an MTP done. Fortunately, after that, she underwent valvotomy, and then she conceived again. So the incidence of cardiac disease varies from 0.1 to 4%, an average of 1%, and about 0.2 to 0.8% of pregnancies have complications with cardiac disease. Pregnancy can exaggerate this pre-existing disease, unmask disease, or a new disease can arise. It could be a congenital heart disease, a rheumatic heart disease, hypertensive disorder of pregnancy, and a cardiomyopathy. Just day before yesterday, there was a huge article on cardiomyopathy at the Times of India, and my dear friend and mentor, Dr. Nozer, is just about coming out of one very, very severe cardiomyopathy in a gynecologist who he delivered. Mild increase in maternal age incidence, prevalence of cardiac risk occurring at a young age, increasing number of women with CHD, peripartum intensive cardiac unit admissions are increasing in frequency. At Fortis Hospital, we do about 40 to 45 neonatal cardiac surgeries every month. So the care of picking up these problems of cardiac disease is still lacking in many, many centers. Women who suffer from pre-existing conditions, elderly primary gravidas and IVF pregnancies, present with multiple comorbidities, congenital and rheumatic heart. The physiological changes, everybody knows that the cardiac output increases by about 50%.
Are you showing slides?
Yeah, are they moving?
No,
No,
we can
no slides at all.
Oh,
iPhone.
I'm so sorry. Oh, I'm so sorry. I don't know. Let me just come back.
We can see the screen, sir, with Zoom screen only. The PowerPoint presentation is not open, sir.
Oh, I'm so sorry. What about now?
Yes,
Yeah,
sir, now it is seen, sir.
Okay, so I'll just start from again.
Yeah, just go.
Already discussed all these things. The healthy woman is important. Then she becomes a healthy mother and a healthy baby. She'll give a healthy baby. The incidence we have already discussed, 0.1 to 4%, congenital heart, rheumatic heart, hypertensive heart disease in pregnancy, cardiomyopathy. Mild increasing maternal age, IVF pregnancies, late pregnancies, present with multiple comorbidities, a congenital and a rheumatic heart. Physiological changes during pregnancy, irrespective of underlying condition, pregnancy imposes a burden on the heart. And all these four things increase. So we'll come to those. The hemodynamic parameter, you can see blood volume increases by 40 to 50%, heart rate increases by 10 to 15%, and the output increases by 30 to 50%. And this happens at its peak at 32 weeks of pregnancy. And during delivery, another 50% increase. Stroke volume, first, second, and third trimester increases between 300 to 500 ml per hour, per contraction, sorry. So we have to categorize every cardiac disease into 4 situations. WHO 1, 2, 3, and 4. 1 is mild disease. There are definite parameters. 2 is moderate disease. 3 and 4 definitely need a tertiary care delivery or sometimes even a valvotomy at 32 weeks. So the risk stratification is very important here. We have to look at the risk in every patient. And this chart should be there in the labor room of all gynecologists. This is the most important category. It is the CARE-PREG study and the ZARA prediction score. Talk about prior arrhythmias, New York Heart Classification, left heart obstruction, cardiac medication before pregnancy, systemic AV regurgitation, pulmonary regurgitation. Obviously, the cardiologist is going to do all this. And then we give them points of which category they belong to. Additional risks: anemia, infection, smoking, physical labor, weight gain, multiple pregnancy, caffeine, alcohol intake, and drugs. So what is the counseling that we need to do? This counseling in a patient with established cardiac disease has to be done by an MDT or a multidisciplinary team. We have to have a cardiologist, we have to have an anesthetist, we have to have an intensivist, a pediatrician, and a gynecologist. And this is how the assessment is done. Evaluation, history taking, WHO 4 category, pregnancy not advised. The disease has to be corrected. And in the lower categories, that is in 2 or 3, risk prediction has to be done. In WHO 1 category, we should go ahead and allow them to deliver. The risk of maternal cardiac vascular complications, underlying cardiac diagnosis, ventricular and valvular function, functional class, presence of cyanosis, PA pressures, any pressure above 32 is extremely important. It's time gynecologists learn how to read a CBC report and diagnose a thalassemia, and also read an echo report. That is very important. Comorbidities including, for example, rheumatoid and musculoskeletal disorders like the Marfan syndrome. Assessed taking into account medical history, functional class, saturation at bed when she comes to you for the first time, pulse when she comes to you for the first time has to be recorded and put it on paper, and disease-specific risk should be assessed using the WHO and the CARE-PREG, that is cardiac disease of pregnancy classification. The maternal risk and complications, effect on pregnancy, worsening cardiac status, decompensation, CCF. Extremely important in all patients that we find out whether she has breathlessness. Never ever neglect a patient's breathlessness. 9 on 10 times it could be because of acid peptic disease, but we tell our patients that if it doesn't resolve, we will get an ECG and an echo done if necessary. During pregnancy, the cardiac output increases between 28 and 32 weeks. During labor, we read in the earlier slide, more than 50%. Any infection, dental infection, oral infection can kind of precipitate a bacterial endocarditis, pulmonary edema, pulmonary embolism, rupture of an aneurysm, effect of heart disease on the pregnancy, weight gain, preeclampsia, abortion, preterm labor, IUGR, hemorrhage, abruption, congenital heart in the baby, and IUFD. I think these are things that we need to definitely pick up. So counseling, we have already discussed. All the related faculties should be there. All the fraternities, the pediatrician, the intensivist, and the anesthetist. The entire team has to be there when the counseling is being done. And how do you diagnose? History taking, examination, and investigations. Clinical features that will mimic a heart disease: dyspnea, orthopnea, PND, easy fatigue, dizziness. Clinical indications: progressive dyspnea, chest pain, patient telling you that when I lie down, I get a cough, hemoptysis, and syncope. Examination signs: increased pulse rate, water hammer pulse. A water hammer pulse is a forceful pulse with a rapid upstroke, descent. I think we are losing touch on looking at the pulse of the patient, but please put your finger on the pulse of the patient, your 3 fingers. That will give you a lot of information. In cardiac disease, in every post-op patient, I think a pulse rate is the most important finding. Systolic murmur, left axis deviation, edema, congested neck veins. You could have cyanosis, clubbing, arrhythmia, persistent neck veins, pulmonary hypertension, cardiomegaly, a diastolic murmur, which could be 3 to 4/6, persistent split second sound. Changes of ECG, I won't go into the details, but you must learn at least what is the T-wave inversion. Basics of ECG we should definitely learn. Monitoring, investigations, you could go from Holter monitoring to transesophageal echocardiography, which is a facility we have, but an ECG and an echocardiography are extremely important. Lung ultrasound, CT scan, we cannot do unless it is an absolute emergency. MRI, genetic testing, and counseling are advanced investigations which we have to do if they are necessary. In pregnancy, 12 weeks ultrasound for major cardiac disease, and echocardiography. I think this is one message that I would want to give everybody who's listening here. We must do an echocardiography whenever possible, especially in patients with history of cardiac disease, because it can run in families. I would always do an echocardiography in a patient who's a diabetic patient, because we know that patients with uncontrolled diabetes have a higher incidence of cardiac disease in the babies. Prenatal diagnosis, if the patient can be diagnosed before pregnancy, nothing like it. The class, again, I don't want to repeat the class, but the patient has to be put in bold letters as to which class she belongs to. And if it is 3 and 4, she should be either transferred to a tertiary care hospital, or your hospital should have the facility to manage these patients. Interventions during pregnancy, if there is absolutely necessary, the best time to do a surgery will be in the 4th month. Intervention could be a STEMI, that is a graphy or a valve replacement, a cardiac surgery, which is extremely rare, has very high morbidity, but we've had a couple of patients in which we've had to do a valvotomy to save the patient's life. A STEMI, of course, is ST elevation for myocardial infarction. Specific lesions are 3 categories: those which increase the volume, those which increase the pressure, and those which produce cyanosis. And of course, a cardiomyopathy is a googly. For a gynecologist, you will never be able to pick it up before delivery. It's always a perinatal or a diagnosis just after delivery. For volume overload, it could be ASD, VSD, PDA, or a mitral or an aortic regurgitation. Pressure overload would be congenital aortic stenosis, coarctation, stenosis, rheumatic heart. Remember, because it is increasing pressure, because there is more resistance. And a cyanotic heart disease could be Epstein's anomaly or a tetralogy of Fallot. Management, high risk of suspicion, timely diagnosis, effective management, and a team approach. Please, from today, at least do one thing. When a new patient comes to you in your clinic, put a stethoscope on the heart, and 9 on 10 times you'll probably diagnose and manage or save a cardiac disease in pregnancy. Hypertension, I won't go into the details. It's a topic on its own. Some tips from my side: management of heart failure in pregnancy. We will not manage the heart failure. We will call a physician or a cardiologist. But please have these some injections in your crash cart. Simdax, levosimendan, is something that we should have in the hospital. Let it expire, because God forbid you have a medical emergency and you call a cardiologist, he may not have this drug with you. This is something that is used to manage heart failure in pregnancy, so that at least when he comes and if he advises, we can have this product freely available in the obstetric hospital. Again, patients with valves and mechanical valves and anticoagulants, we again see a lot of these patients. These patients could be on VKAs, that is vitamin K antagonists. If they are on warfarin, they have to be changed to either unfractionated or fractionated heparin. This chart is something that all of us must very, very clearly have. Woman with a mechanical valve and high dose VKA, that is warfarin or a fenprocuronum, you must see to it that she's switched to an injection, and the cardiologist is to be taken into confidence. We have to change them to heparin or unfractionated heparin. Time and mode of delivery, timing of delivery, labor induction, vaginal or cesarean, depending upon the class of the patient. The patient's second stage has to be monitored. It has to be short. Delivery in an uncoagulated patient, again, we need to be extremely careful. Protamine is another injection that we should have in the hospital, especially if a patient is on heparin, because if she comes in a labor and it's not 6 hours since she's taken her injection, we can give them a protamine injection. Urgent delivery on therapeutic anticoagulation, hemodynamic monitoring during pregnancy, during delivery, anesthesia, labor, these patients should ideally be delivered in the OT. I have done one perimortem cesarean section for a patient who was almost on the verge of being declared as clinically brain dead, postpartum care, and breastfeeding. Preconceptional counseling, no pregnancy unless there is a okay from the cardiologist. Maternal mortality varies depending upon the class. Optimum medical and surgical treatment pre-pregnancy. Maternal and fetal risks, prognosis, cost considerations are extremely important because no matter what we say, in our country, the patient has to bear the cost. Hospital delivery, preferably at a tertiary center. Medical termination of pregnancy is indicated in these patients: primary pulmonary hypertension, Eisenmenger syndrome, coarctation of aorta, Marfan syndrome with dilated aortic root. Only in the first trimester, better before 8 weeks of pregnancy. Suction evacuation is preferred. MTP also carries a risk for life. Care during pregnancy, at least 2 or 3 visits by the cardiologist, a careful blood pressure monitoring, look for cough, dyspnea, weight gain, anemia, auscultated lung basis, keep looking at saturation of the patient, ensure true compliance, exclude fetal congenital anomaly. This is extremely important. So we are a high-risk center. So we do a fetal echo in almost all our patients. Special advice: rest, avoid excitement, diet, iron, vitamins, hygiene, dental care, extremely important. Salt restriction, extremely important. Avoid smoking, drugs, and beta mimetics. Therapeutic prophylactic cardiac interventions as applicable. Benzodiazepine, penicillin for rheumatic heart disease. Diuretics, beta blockers, digitalis, anticoagulants in patients with a mechanical valve. Surgical treatment, a valvotomy, ideal time would be between 28 and 32 weeks. Indications for admission: NYHA 1, 2 weeks before EDD, NYHA 2, 28 to 30 weeks, NYHA 3 and 4, irrespective of period of admission, electively admitted. Emergency admission: deterioration of the functional grade, breathlessness, fever, anemia, infection, abnormal weight gain, other medical disorders. Labor management: try and cut short the second stage of labor with a vacuum or a forceps. Deliver in the OT in the presence of an anesthetist. Propped up position, very, very important. You could induce labor with a Foley's catheter or with a Cerviprime gel. And management of second stage of labor, propped up position, oxygen, epidural definitely preferred so that the patient doesn't get anxiety. Caution: give fluids at 60 to 70 ml per hour. You have to have a syringe infusion and IV fluid infusion pump for this. Stop anticoagulants, digitalize the patient, look for pulmonary congestion. These are drugs which should be there in the hospital: Derifulin, Lasix, and other drugs. Propped up position, avoid forceful bearing down, adequate pain relief, cut short second stage of labor, and deliver in the OT. First hour after delivery, propped up position, sitting position, oxygen, watch signs of pulmonary edema. As soon as this woman delivers, if she delivers normally, put in a Foley's catheter and give at least 20 milligrams of Lasix. Because you know there's going to be a reverse increase in the load on the heart. Sedate the patient with morphine or whatever drug that is available. Give good antibiotics. LSCS, mainly obstetric, but coarctation of aorta, elective indication. Marfan syndrome with a dilated root. Severe mitral stenosis, deliver between 34 and 36 weeks, depending upon your NICU care. Continue medical treatment, avoid infection. Reassess at 6 weeks. Iron supplementation, cardiac consultation for definitive management of heart disease. And depending upon the category of the patient, subsequent studies, subsequent investigations, and breastfeeding, extremely important. But depending upon what drug she's on, if she's on warfarin post-op, you can't give them because everybody cannot afford low-dose heparin. Key messages: please look after the patient well, do systematic evaluation, risk estimation, indications for intervention, plan delivery, counsel the patient very, very well much in advance as to what kind of delivery plan you have for the patient. And finally, friends, care should not start in the emergency room. This has to be a planned delivery. Thank you very much.
Yes, Dharmesh Patel, sir. Remarks, please.
Dharmesh is muted.
Sir, you have and my son, Dr. Pinky Kataria.
Pinky, Dr. Pinky.
Okay. You have mentioned very nicely and narrated all the possible complication from antenatal to postpartum. And what the now scenario is changing, the people are getting at older age with the pregnancy. So, and mostly they have planned as far as the IVF concerned, ART pregnancy with patients sometimes come with the and with the history of the some apart from the congenital and the valvular, people come with the some cardiac issues also. So, what kind of precaution for that high level of that is some patient which come with the ischemic heart disease, like what extra precaution would you suggest for that people?
So there are a couple of things. One is we will obviously take a cardiologist's opinion and find out and put them into the category of disease that I mentioned just now. Number two is very, very careful diet instructions have to be given to the patient. I will send her to a dietitian, or we have a complete package here at our clinic. This patient should not be allowed to put on more than 6 to 8 kgs in pregnancy. So she has to have a high protein, low carb diet, depending upon what her pre-pregnancy weight is. A proper counseling for the amount of salt that she will consume. We do not realize patients in the first 3 months of pregnancy have cravings for very, very spicy and very oily and very food which is very salty. All these instructions have to be given. I would see, if I'm seeing a non-cardiac patient once in a month, I would see this patient every 2 weeks, monitor her weight gain carefully, see to it that she takes her medicines carefully, counsel the family as a whole to see to it that the family members are equally involved in the pregnancy, especially the husband and the mother-in-law, because they are the ones who are the caretakers at home. And she should be given a contact number for an emergency. So God forbid she has a problem, and she should be given a list of symptoms for which she will report to us immediately.
Thank you, sir. Thank you all team.
One question, if you allow, then I.
Yes, madam. Yes, ma'am.
Yeah, okay. If a patient is stenotic, suppose mitral stenosis, and goes for regurgitation during second trimester, and then if cardiologist feels okay, she may require diuretics. Then how long we allow diuretics once she is out of short of failure? Because we are worried as an obstetrician about fluid that is oligo, if diuretics given for a longer time. So we have to weigh pros and cons. Then for how long we allow diuretics if she goes to a regurgitation?
So now, in a situation like this, you will have a multidisciplinary meeting with the patient, the cardiologist, and the gynecologist. And if the cardiologist feels that the diuretics are necessary, he will be allowed to give the diuretics. And we will monitor the LICR volume on a weekly, 2 weekly, or a 1 monthly basis. Because if the patient is healthy and alive, she will give a healthy baby. So she has to be counseled accordingly. So it's not an individual decision. It's not a gynecologist decision. It's not a question of we allowing. It is what is necessary. And
what is the optimal interval when we can reduce or rather stop diuretics?
Madam, I don't think it's a gynecologist's decision.
It is cardiologist's decision. Of course, we know.
So if, for example, if she's 28 weeks.
Yeah.
And her AFI is 15. We will monitor the AFI of the patient. Not all patients with 10 and 20 milligrams of Lasix develop oligohydramnios.
And they are giving potassium-sparing diuretics. So we are not.
So lacilactone. They would probably give lacilactone to the patient.
Yeah.
These patients, we have to monitor their electrolyte levels. And we have to monitor their LICR. That's the gynecologist's role. The rest is to be left to the cardiologist. And depending upon what your center is capable of managing a neonatal, a child, that is our center.
Then this is optimum time we will take out the baby.
700 grammars also we will be able to manage at our hospital in Fortis and in Mumbai. So I think that optimal period, safe period is what is to be defined. And the family has to be counseled accordingly.
And second is, suppose we are taking out this baby prematurely, like we are giving, suppose patient is on insulin or a GDM patient, then betnesol. Is there any extra precaution if we are giving corticosteroid antenatally in cardiac patient we need to take?
No care is to be taken. You have to just tell the patient that ideally what I do with my patients who are diabetics now, we counsel them to put a CGM or continuous glucose monitoring system.
Yeah,
When we give them steroids, their sugar levels are going to go up. So we have to tell them that you report to us what is your sugar level with a CGM, not with a finger prick, because you can't keep pricking again and again.
we don't.
The
We
dose
also
has to
don't.
be adjusted. It will take between 3 and 7 days for that sugar level to come back to normal.
Yeah,
So at
suppose.
that time, the dietary sugar has to be controlled.
Yeah. Suppose same way patient is cardiac. Is there any difference in corticosteroid management?
No, it's the same. Betnesol 12 milligrams, 24 hours apart.
In prognostication wise, if cardiomyopathy, I have one patient with cardiomyopathy too.
So if the minute the ejection fraction is low, I mean, I have not in 32 years of my practice not seen many cardiomyopathies. Most of them are perinatal, just about to deliver, or they come to us with breathlessness. The baby comes out, as simple as that, because cardiomyopathy will not be managed unless the baby comes out. Because they have to be digitalized, they have to be given Lasix, they have to be in the ICU for management of all the other medical problems that they have.
And does digitalization make any difference on neonatal outcome?
No.
Okay. Thank you, sir.
Thank you.
Sir, what is the mitral valve area where you decide whether to go for a BMV prior to the pregnancy, or you can do it in the second trimester?
One is symptoms of the patient, and any diameter, anything above 1.4 is good. If it's less than 1, it's a tight stenosis. I mean, if picked up early in the first trimester, we would suggest termination of pregnancy. If she comes to us at 28 or 29 weeks or 32 weeks, then things become difficult. So we have about 1 or 2 patients a year on which we do a valvotomy.
And one more, sir. I have one young girl who is diagnosed with cardiomyopathy, absolutely asymptomatic, 23 years of age. And their parents' query is now whether to declare to whenever she is planning for a marriage or pregnancy. Cardiomyopathy, how it will affect her future obstetric career. Then how to counsel with such patients?
So this is basically something that they have to tell the family and the in-laws that she has cardiomyopathy. And if the ejection fraction is less than 30% or 32%, she should have.
It is around 40%. She is maintaining with 40% around.
With the cardiologist's opinion, she can be, with guarded prognosis, she can be allowed to get pregnant.
Okay, that's
it's a Dr. Darshana, it's a social issue. You have to balance it, because you can't just one day tell to the in-laws that she has this disease. It's always better to counsel this patient prior to the marriage, whether what are the pros and cons of continuing pregnancy, what should be the ideal ejection fraction to continue without any maternal mortality. So it's more of a social decision. You have to take a spiritual and realistic view while doing all this management.
And these are patients on whom surrogacy can be discussed also.
Yes, sir.
Excellent suggestion, sir. Surrogacy we can offer them.
Can be discussed
on
if
medical
ejection
ground.
fraction is less than 30%. Last question to Dr. Atul, sir. What is your experience about the metallic valves in the patient and how to go about the warfarin, heparin, and heparin changes? How do you suggest to have minimal side effect of warfarin syndrome?
So there are 3 issues here. One is warfarin cannot be given in the first trimester of pregnancy. Ideally, it should not be given in pregnancy at all. The third thing is we would want to give them unfractionated heparin of 5,000 units twice a day, or you can give them LNWH once a day. We have to switch them over. After first trimester, the decision of the family and the cardiologist whether they want to switch them back to warfarin. It is contraindicated in breastfeeding.
And like for warfarin, we monitor the PTT key, PTA, INR. What about the heparin, low molecular heparin? Any drug.
LMWH, no monitoring is required.
Much better prognostic.
How do you
with,
decide the dose on this patient, whether to go for 40, 60 on the 50 milligram per kg, 1 milligram per kg,
1
or
mg
any?
per kg ideally.
Yes.
And if it is a mechanical valve, sometimes they say twice a day.
And I have used throughout pregnancy. I preferred in few cases I have treated with heparin, LMH this, and I was much happy with of course with cardiologists, but rather than warfarin, heparin is better because we can
warfarin-
control the dose, when to withdraw. Suppose bleeding is there, or we have to deliver immediately within 34 means 24 to 36 hours baby. This delivery interval after stopping of this heparin, the neonatal outcome is better compared to mother is on warfarin.
The problem with warfarin is depending upon the dosage of the warfarin, the INR goes up. I have seen, and the cardiologist will say, and the cardiac surgeon will say, maintain the INR to around 2.5. They don't want INR to come to less than 2.5, which can be risky. They can have a first trimester bleed. They can have a bleed in pregnancy. They can give you difficulty during labor if she comes accidentally with either a leak or a PROM or an abruption. So I think we have to counsel them. And now in these patients, I personally take charge of giving them the heparin at very, very low cost. In fact, I even talk to companies and says they will buy 20.
We also do the same thing. Company will supply them directly. And this pain is also helpful.
Yes. Because APTT, PTINR and platelet count. Even with unfractionated heparin, the platelet count does drop sometimes.
Thank you, Dr. Atul sir, for this insightful talk on heart disease in pregnancy, which is very important and life-saving initiative for all the high-risk obstetricians who are doing the practice of managing such patients. You have a good backup at Fortis Hospital, and you have developed the high-risk unit there in a very, very strong way. And you get a lot of references. That's what your experience speaks a lot. We are really thankful to Dr. Atul sir for this insightful talk. And we thank Dr. Atul sir for giving us time, 1 hour time for this talk. Thank you so much, sir. Now we'll move to the second session, that is a panel discussion. Over to Dr. Monica.
Thank you. Thank you, Atul sir, for accepting our invitation gracefully and speaking on an obstetric topic, but with your expertise, because I have always heard your endoscopy talks. So thank you so much, our chairpersons, and we move on to the panel discussion, which is a case-based discussion on puerperal sepsis. Our moderator is none other than Dr. Kalyan Baramde sir, with our expert, Dr. Girija Wagh madam. Sir, sir is the president of IAGE. Sir has been the past chairperson of Infertility Committee of AMOX, as well as he is currently the IMA Maharashtra State Vice President. He's been the president of the Latur OBGYN Society and Latur IMA.
Ma'am, thank you. Next,
yes,
please.
Please change to the next slide, please. Our expert, Dr. Girija Wagh madam, is a professor and head of the department at Bharati Vidyapeeth Medical College. She has been the past vice president of FOXI. She is also has been the chairperson of the medical disorders of pregnancy in FOXI, vice president of India Justice.
Thank you so much, Monica. Thanks a ton. Thank you.
And can I now introduce our panelists, please? Dr. Ramanlal Trivedi sir is a chief consultant at Avatar Hospital at Santrampur. He is currently the president of Godhra OBGYN Society. The next slide, please. Dr. Puneet Khatri sir is a practicing gynae endoscopic surgeon and IVF consultant in Mandvi, Kutch. He has been the past president of the Bhuj OBGYN Society. And his paper on high dose of calcium in preeclampsia has been awarded the best paper at Sobog in Anand in 2009. We welcome you, sir. The next slide, please.
Welcome, Puneet, sir.
Yes. Dr. Jigna Gadnatra madam is a certified Indian menopause practitioner and an FMM certified OBGYN sonologist. Our next panelist is Dr. Ankita Godkar. She has been working as a lecturer in the Goa Medical College and as an associate professor in the Department of OBGYN since Dr. Sunil Kumar Patel, sir, is a senior gynecologist and laparoscopic surgeon at Navjeevan Hospital. He has been this, please, the previous slide, please. Yeah. He has been the state vice president in 2007 and 8, the honorary zonal secretary in 25-26, and the president in 2003 to 2004. He has been the ex-zonal representative of the Indian Medical Association also. We welcome you, sir. Dr. Gaurav Garbi is a senior gynecologist at Akshar Hospital, and his professional background is expertise in fertility, laparoscopy, and painless deliveries. We welcome you, sir. Our next panelist is Dr. Karthik Shastri. He is an active member of the Public Awareness Committee right now from Gujarat. He is also director of the Astha Maternity Home at Rajkot, and he is the secretary of the Rajkot OBGYN Society. We welcome you, sir. Dr. Darshana Pandya, madam, is a consultant at Ashutosh Maternity and Surgical Hospital. She is honorary gynecologist at Sterling and Wockhardt Hospital and an ex-assistant professor at the MP Shah Medical College at Jamnagar. She has been nominated for the Women of the Year 2002 by the American Biography Institute. She has also received the Wanda Foxy Award in 2019 and the Foxy Brahmakumari Award for the awareness of breast cancer and cervical cancer. We welcome you, ma'am, as an esteemed panelist. And over to you, Kalyan sir, for the panel discussion.
Thank you, Dr. Monica, madam, for all this introduction. And we are going to have a small case-wise discussion on puerperal sepsis. This is a very important topic to talk because the mortality still has been not reduced in India. And when you talk about the puerperal sepsis, we need to talk about the different. This is the introduction of all panelists: Dr. Ramanilal Trivedi, Dr. Puneet Khatri, Dr. Jigna ma'am, Dr. Ankita madam, Dr. Karthike, Dr. Sunil Patel, Dr. Darshana madam, and Dr. Gaurav. Welcome all. So now, when you talk about the survey, WHO said puerperal sepsis is defined as infection of the genital tract occurring at labor or within 42 days of the postpartum period. And it can be a complication of delivery, either normal, cesarean, or even a miscarriage. The primary sites of infection can be a perineum, it can be vagina, cervix, or uterus. So that's what is very important for us to discuss. And now coming to the first question, what is the puerperal sepsis and how you differentiate with reproductive tract infection? Dr. Puneet bhai. Dr. Puneet Khatri, can you just unmute, please?
Yes, am I audible, Dr. Kalyan?
Yes, sir.
Am I audible now?
You are audible.
So basically, puerperal sepsis is a infection of genital tract 6 weeks, and yeah, and a difference between puerperal sepsis and reproductive tract infection, right? So the reproductive tract infection which occurs in case of non-gravid uterus, non-pregnant state. And basically, in puerperal sepsis, the signs, symptoms are mostly the high-grade fever, pyrexia, with or without pain in the pelvis. Mostly the common presentation is like this. But in reproductive tract infection, which may occur, the definition is like it occurs in non-pregnant patients, and the symptoms might be vaginal discharge with or without foul smell. Pelvic pain may be present or may not be present, and normally reproductive tract infection like cervicitis, vaginitis, PID usually present without fever. Usually pain and discharge is the main.
Very rightly said by Dr. Puneet sir.
The
one which is there is a reproductive tract infection is in a gynec, and puerperal sepsis is an obstetric cause within the PNC period. Over to Dr. Jigna Ganatra, madam. What are the predisposing factors in the antepartum period and intrapartum period for puerperal sepsis?
During antepartum period, if usually in our country like India, the majority of the patients are anemic. So anemia, malnutrition, these are all definitely the predisposing factors. And definitely, usually we advise nowadays to get done glucose challenge test or HbA1c. Usually we advise hemoglobin electrophoresis, but diabetes is also a major predisposing factor for this. And other already patients who are having means vaginal infection before pregnancy, they are more susceptible during pregnancy. And preterm labor or premature rupture of membrane or precipitate delivery, and also immunocompromised patients are also more susceptible for infection. And usually intrapartum factors are usually if it is associated commonly by repeated vaginal examination, retained bits of placental tissue, foul smelling lochia, or any of the prolonged labor, obstructed labor, or instrumented delivery. These are all the intrapartum factors which may be predisposing for sepsis.
Thank you so much, ma'am. You are elaborated about the antepartum and intrapartum factors of sepsis. Now, coming to Dr. Karthikeyan from Rajkot. Dr. Shastri, you are there? What are the organisms of normal vaginal flora? Dr. Karthikeyan Shastri is there?
Yes, sir. Yes, sir. I am here.
Yes, sir. Organisms of normal vaginal flora.
We usually encounter the Lactobacillus genus throughout the normal vaginal flora.
Yes. Any other?
Am I audible, sir?
Yes, sir. We are listening to you. Dr. Monica? I think now we go to Dr. Ankita Borkar. Dr. Ankita is there?
Am I audible, sir? Hello?
Yeah, now you are audible, sir. Boliye.
Sir, we usually encounter the different species of the Lactobacillus as a dominant normal vaginal flora, including the anaerobic bacteria, including the bacteroid species, the Streptococcus, the Corynebacterium,
and bacteroids.
And even yes, and the bacteroid species.
And what are the common puerperal infection we come across in the day-to-day practice, Dr. Karthikeyan? Dr. Shastri, are you audible?
Yes, sir. Yes, sir. Sir, commonly the postpartum we usually acquire the local vaginal infection due to the vulvovaginal candidiasis, the bacterial vaginosis, even leading to the puerperal sepsis, sir.
Okay, so the commonest found are wound infection, either in the episiotomy or cesarean, postpartum endometritis, mastitis, or even UTI can cause this infection. And now we are coming to Dr. Jigna Ganatra, madam. Dr. Jigna, ma'am.
Yes, sir.
So how would you explain and what is the difference in puerperal infection, puerperal sepsis, and septic shock?
Okay. Sir, usually puerperal infection is whenever we do, whenever a patient comes with postpartum to us, and whenever we examine her per speculum examination and we found abnormal vaginal discharge or foul smelling discharge, that is typically fitting into infection. And that is bacteremia, means presence of viable bacteria in the blood. So definitely if we have sent culture and that shows organism, that proves that this is definitely fitting into puerperal sepsis. And typically, shock is defined as typically if patient is tachycardia, hypotension, and high-grade fever, persistent high-grade fever, and all clinical parameters along with laboratory parameters altered, then it is definitely septic shock. So, sepsis with hypotension refractory to fluid resuscitation, that is that needs vasopressors and multi-organ support, that fits into typically septic shock.
So Dr. Jigna has rightly said about infection, which is an inflammatory response to the presence of organisms. Sepsis is tissue damage due to dysregulated host immune response to the infection. And septic shock is sepsis with hypotension, which might require a multidisciplinary approach to treat these patients. And now coming to Dr. Gaurav, he's joined. I don't think. Dr. Darshana Pandya, ma'am, what are the best strategies to prevention of sepsis and its sequelae? Can you unmute, madam? Dr. Darshana Pandya? Yes, ma'am.
This implies everywhere. Prevention is better than cure.
Better than cure, right.
So very much important is prevention. Then as you this mentioned here is high index of suspicion. Okay, which are the patients which are likely to go for puerperal sepsis? Even if she goes for sepsis, then early diagnosis. Again, it implies for everything that high degree of suspicion by a clinician and early detection. So these are the high risk pregnant ladies who are supposed to be, we are supposed to be little more vigilant to prevent sepsis, as Dr. Jignabin said, is GDF. And I prefer OGTT very early. Those who have either history or high risk for GDF, then multiparous patient, those who are low socioeconomic class, those who are, this our setup is not properly, we are not maintaining the septic precautions, antiseptic precautions. Those who are having any medical disorders with pregnancy, preeclampsia, anemia, twins are again, we used to say that any twin pregnancy can go for any obstetric complication. So twin pregnancy, and these days, as you again you are showing, that is autoimmune disorders, because their immune system and vasculopathies, they have altered vasculopathy and immune system. So they are also again high risk for developing of any postpartum complications. Especially, we have to prevent sepsis in such cases, because if they have septic embolism, then thing will be the worst in cases of those who are autoimmune pregnant ladies. So any immune disorder, whether immunocompromised or autoimmune, then this is they are at the high risk. And we have to avoid multiple this PV examination. Partograph is best to use to prevent, as again Dr. Jignabin has mentioned, those who are having prolonged labor or obstetric labor or instrumental delivery with perineal tears or episiotomy which is not properly sutured, then they are at a high risk of development of puerperal sepsis.
Very rightly said. Dr. Ankita Borkar, who is from Goa, you want to add something, Dr. Ankita?
As far as prevention is concerned, sir?
Right, ma'am.
Yeah,
what
so
are the strategies in the ANC period? Like right now, she said at 28 weeks, you like to do a GTT, you like to do a urine routine examination, or you go on a only basis of the history. What you are going to decide about?
I would also like to add to this. These are all valid points, but I would like to add that in pregnancy, early signs of sepsis are often difficult to pick up. And that is why we should have a high index of suspicion. So even subtle signs like sudden tachycardia, rise in the pulse rate, or if the patient is complaining that she is feeling unwell, telling them about, warning the patients about certain red flags, like if she has any foul smelling discharge, or if she notices rash on her body, or any sort of say, for example, in the puerperal period, any breast lump. So warning them about these subtle signs of and symptoms of infection would also go a long way in having them early for treatment.
Very, very important is breast. Postpartum period, breast engorgement is very common. And when they are neglecting breast engorgement, milk is the richest source to develop bacteremia. So they develop, once breast engorgement is there, breast lump is there, then we have to explain them for manual expression of breast milk very thoroughly. Otherwise, they will go for mastitis and development of infection very rapidly.
So high index of suspicion, risk stratification, early diagnosis, and prompt treatment is what is required in the cases of for prevention.
And those who have a history of repeated urinary tract infection,
UTI,
that we should not neglect.
And Dr. Jigna Ganatra, how does this spread occurs, where it starts and how it goes into septicemia, that is from pelvis to tubes to abscess to septic? What is the route and how does it go long way?
Already the postpartum patients are having as compared to normal patient, these patients are having little bit of, they are more susceptible for infection. So usually from endometrium, if there are retained bits or if there are lacerated wounds in the cervix or in the vaginal wound or a lacerated wound, the infection ascends upwards. And then it causes inflammation or an infection of both the fallopian tubes. So it leads to infection from fallopian tubes. It may spread to pelvic abscess, and infection spread to this area also. And then it will gradually lead to goes into circulation also, and that lead to septicemia and septic shock. So main route of infection is ascending infection through this pelvis and or this local part. That is the main route of infection. And also this devitalized tissue, blood clots, and they all spread the infection. And ultimately it leads to salpingitis, parametritis, endometritis, and infection.
Very rightly said by Dr. Jigna. It will devitalized tissue from the local tissue from cervix, vagina to salpingitis, abscess, and even this entity which is called as septic pelvic thrombophlebitis is very common, where pelvic infection lead to infection of the vein wall and intimal damage, leading to thrombogenesis in the veins, and they can move towards the vital organs like lungs and the kidneys and can cause septicemia due to hemolytic streptococci, rhizobacterial endotoxin causing circulatory inadequacy and tissue hypoperfusion, which can cause lung abscess, meningitis, and other things. And in such cases, septic shock, the death rate is around 30% of the cases. Now, coming to Dr. Karthikeya Shastri, what is the risk stratification on admission to the labor ward? The patient with sepsis has come to you. What is MEOS scoring system? Dr. Shastri, can you unmute? I think he's unmuted only. Dr. Puneet Khatri, I can't see. Dr. Ankita, again, from Goa. You know about this risk stratification in the labor ward, that is MEOS scoring system?
Yes. Yes, there is a scoring system which is based on the vital signs, which includes the oxygen saturation, respiratory rate, heart rate, blood pressure, and temperature. And there are colored markings on the chart. So if the reading falls into the red category, we know that it is something that needs to be taken seriously. If it is amber, then it is somewhere in between, and the yellow would be the normal values for each of these parameters. So it is a single chart that helps us to know where the patient stands as far as the her general condition is concerned.
Rightly, very rightly said about this risk stratification, because what is important is once the patient comes to the labor ward or to your unit, you should be ready in managing within first 1 hour. That is a golden hour for these patients, which can just save their lives whenever these patients come to you. So what are the red flag signs of pupil sepsis, Dr. Darshana? Dr. Darshana Pandya, or I think Dr. Puneet Khatri, or Dr. Jigna can take this. Dr. Jigna Ganatra, madam.
Yes, typically if patient is having persistent tachycardia, high-grade fever, temperature more than 100.4, that is, then offensive foul-smelling vaginal discharge, severe abdominal or pelvic pain, and tachypnea, typically increased respiratory rate. These are the red flag signs, and definitely wound infection, or typically if we found locally over the episiotomy or any site, typically post discharge from the episiotomy site, or even cesarean section incision site, if we find post discharge, that also is a red flag sign. And typically, whatever our teachers always say, that for any after any operative, gynec operative also, urine barabar aana chahiye.
Very
So
right.
typically, yeah. So
Dr. Jigna has rightly said about the red flag signs. Now, again, coming to Dr. Jigna only, principles of management of puerperal sepsis. Can you just elaborate what you are already told? Just can you highlight them?
yes. Yes, see, everybody is informed that typically recognition and early identification is very important. So I have developed a habit of before discharge, even if it is normal delivery, I usually do a per speculum examination. And after cesarean section also, I usually discharge, even if the patient stays in hospital for 48 hours or so. I usually do per speculum and then discharge each and every patient. Many a times it has happened that in many of the institutes in the busy labor room, some assistant or some staff has kept mop inside, and that is the most common reason. So we have to be vigilant for each and every patient. That is most commonly missed mop or missed gauze piece inside the vagina. That lead to severe sepsis, and I have seen clinically also. Then definitely we are having nowadays, as previously our teachers how they used to manage, we are having better investigation facilities, so we can definitely advise early CRP. And if CRP is high, we can monitor on CRP, WBC count, or we can also PCT is also a good marker to follow, and it is much more reliable than CRP. So and definitely the source of investment means, if we have we are finding pus, then we can send pus swab take, and that discharge can also be sent for culture and sensitivity, and according to which we have to start broad spectrum antibiotics. And definitely supportive care, nutrition, hydration, and definitely I'm working in a corporate hospital, so typically if patients are worsening, then we all are, the team is behind finding the source, and ultimately if source is removed, then patient definitely gets improved. And we have to remain vigilant. If CRP is high, if patient is having persistent fever, we definitely have to advise them admission. So usually after delivery, patients are reluctant because they have small child but we have to explain them that this requires injectable antibiotics. If we delay in giving injectables and we waste further 1 week for oral, and then patient worsens, then it is very difficult to survive the patient. So if these patients, we have to monitor for 24 to 48 hours. If the parameters are not improving, then we may have to shift to ICU and multidisciplinary care as soon as possible.
Very rightly said by Dr. Jigna Ganatra. Yes, Dr. Darshana.
What I would like to add is ultrasound.
Right. We are coming to the next question. You can only, yes,
Yeah.
ma'am. These are the
Ultrasound
principles.
at least one should do.
Yeah. These are the principles. Now, Dr. Darshana Pandya will guideline us about the investigations for puerperal fever and those were suspected puerperal sepsis. And then Dr. Puneet will add to Dr. Darshana.
As I said, to hematologically CBC, urine routine micro and urine culture, both. Same way, blood culture will come afterward, but routinely CBC, urine routine micro, urine culture and sensitivity, thyroid function test, basic LFT, KFT, it's okay, fine. Kidney function test, we have to monitor and not to forget even basic electrolytes, because electrolyte is much important to maintain eusepsis, rather we say it is a the neutral phase. Sometimes when we administer parenteral antibiotics, then parenteral fluid and electrolytes, which electrolyte which we have to give. And serum potassium is very much important when to early suspicion of kidney compromise, because then once multi-organ failure is establishing, then we are led to intervene. So kidney function test and PT with INR or APTT is also, to me, not only PT with INR, but APTT when we are monitoring advanced cases of sepsis, then APTT and PCT. Especially as you are mentioning, when patient is in septic shock or multi-organ involvement, then serum lactate is prognosticating factor. CRP, PCT, a blood gas analysis when we are suspecting acidosis, and we have to maintain vital to prevent multi-organ involvement. Then blood gases, blood culture, urine culture, high vaginal swab is very much important to know the because sometimes it is refractory gram-negative organisms are there, and then we have to manage our parenteral antibiotic accordingly. As I have told, ultrasound to rule out retained product of conception or placental tissue. It is my routine, even if patient is asymptomatic. As Dr. Jigna has told that PS is done, but I always do trans-abdominal sonography once we are deciding the patient. And single line endometrium is always satisfying that there is no retained product of either placenta or conception. And when it is we are suspecting of septic shock or multi-organ involvement, then CT or MRI to see peritonitis. Because secondary peritonitis, if it is occurs, then it is very difficult to treat, rather than to detect peritonitis very earlier. And when it is free fluid in the peritoneal cavity, we should put a drain. So septic focus is always out. And when we are intervening in such cases, those who are, when we are suspecting that these are the patients who are likely to go for sepsis, then I always put in intraperitoneal drain at the time of cesarean.
Very rightly and clearly given message that the hematological test, specific hematological test, cultures, ultrasound, and if required, CT, MRI is must for any of these cases. Dr. Puneet Khatri, you want to add something? Puneet bhai. Okay, coming to Dr. Ankita Borkar, how we are going to know about the source of infection when you ask the history to the patient? Dr. Ankita Borkar.
Yeah, so sepsis in the puerperium, you need to pinpoint the source, and most commonly it is from the genital tract. So it's important to ask about history of any discharge from the wound, which may be episiotomy or the cesarean wound, or discharge from the vagina per se. Any deep pain, which may indicate something like necrotizing fasciitis. Then sometimes there is generalized rash all over the abdomen, which may be a streptococcal or staphylococcal infection. Then other symptoms like symptoms suggestive of urinary tract infection, any breast pain, mastitis, or redness in the breast, any cough or breathing difficulty, which may indicate an underlying pulmonary infection, or it may also indicate worsening sepsis that results in tachypnea and multi-system problems. Any vomiting, bowel disturbances like diarrhea, pain in the upper abdomen as well is important to know. So, yes.
So detailed history in the antepartum period, intrapartum, and even physical examination is very important, which Dr. Ankita has rightly suggested us. And diagnostic criteria for sepsis, according to the Green Top guidelines of RCOG, is general is fever, tachycardia, tachypnea, consciousness level is impaired, edema, hyperglycemia, bruising of skin, inflammatory variables like WBC is increased, CRP is more, Hemodynamic is systolic blood pressure less than 90, mean arterial pressure less than 70. And Dr. Darshana has told about the serum lactate level increasing, which is a prognostic indicator, and organ dysfunction for saving the ABG, platelet count less than 1 lakh, urine output less than 25 to 30 ml per hour are very important. Now coming to Dr. Jigna, again, what is the Surviving Sepsis campaign?
So this Surviving Sepsis campaign 2024 guideline focuses on early recognition and treatment of sepsis and septic shock. That is the only reason we are discussing it today. So to give more and more awareness to the people. So key recommendations according to it include early antibiotic administration, patient and family involvement in care. So whenever we are discharging the patient, we have to explain to the patient in each and every discharge summary. We write in three factors that immediately report to hospital. If you are having high grade fever, any abnormal discharge PV, or any pain over the stitch line, or any discharge from the stitch line, you report to hospital. That we document in the discharge summary and that we explain to the patient also. Then usually it is this thing that I always before the discharge keep standing one of, even no relatives are there ready, I first ask them who is going to do the episiotomy care. Usually many of times it is that they tell that patient will do herself, but it is never possible by the patient. So I always even if no one is there, I tell the husband and counsel him that you can also do the episiotomy care of your wife. So I personally explain them how to do episiotomy care, how to take seats bath. That is very important, which I explain to patient. And this is the same thing that I usually tell that if they take proper care of episiotomy after 1 week, a patient will be completely fine. And also focus on long-term outcome and rehabilitation. So nowadays, more and more husbands are also involved and they are also becoming educated, and they also feel that women definitely require support during the process of delivery. And it is the childbirth is not only the domain of woman, but it simultaneously requires the support from whole family to come out. And typically main advice of them were they typically ask about diet also to us. So we typically explain about diet that these are the things you can give to the patient particularly. That is also very important. So these recommendations are there for Surviving Sepsis campaign.
Thank you, ma'am. Jigna, ma'am, you are on right back on the target about the Surviving Sepsis campaign. Now we have our expert, Dr. Girija Wagh, madam, has joined. So, ma'am, can you just elaborate us about your views on the patient involvement while the discharge? Dr. Jigna has already talked about this, ma'am.
Yeah. So first and foremost, congratulations for the wonderful discussions that have ensued here. I hope I'm audible, Kalyan.
Yes, ma'am, you're seen also.
Two very important topics you decided to discuss. One was heart disease, and it was wonderful talk given by Dr. Ganatra. And also I looked at the discussions which happened, and I'm very happy that everybody is so aware of these things. The reason why I'm saying so is because I am also catering to a lot of tertiary care patients who are coming to us, who have been referred, and usually now we are finding the most important reason for morbidity is the sepsis. Now, there are some important experiences that we have had while on field, which I want to share, and they're very practical. And if at all, if the time permits, I can also tell you 1 or 2 cases. Now, one thing is hand washing in the labor room, in the operation theater. We feel that Manyata, NABH, all of them are typically talking of it all the time. But believe me, friends, that has gone a long way in reducing sepsis. Even in my own institution, we placed a CCTV camera in the operation theater in the labor rooms, and we found that many of the doctors are not doing proper hand washing. And the moment this was put up, there has been a drastic reduction in the sepsis incidence. So don't take these hand washing things. So very much important in the labor room, operation theater, and as well as in the wards, it's very important. Secondly, every institution, maybe it's a small facility, we need to have our antibiotic policy. Your antibiotics have to be specific. What are your commensals? What are going to be your pathogens? That will determine what is going to be your antibiotic policy. You can refer to the government policy. Government comes up with the policy. You can make that as your baseline framework and create your own antibiotic policy, because giving indiscriminate antimicrobials causes challenges, and then that sepsis can hit you back very badly. And very importantly, what we also found was giving that antimicrobial right at the onset of a C-section. For example, C-sections are very much on the rise, and it's believed that many people are taking out the uterus out. I understand that sometimes for safety, or if there's bleeding or there's extension of wound, we may require to take out the uterus. But if at all it is avoidable, you can first close the entire uterine cavity and then take out the uterus, so that you will reduce the incidence of endometritis and sepsis. That would be my, that's a practice that we also follow. Second most important thing is keeping placental bits inside. You don't know, Kalyan, how many patients we have dealt with in our institution where these patients have undergone, especially it is very commonly seen with IVF conceptions. That's why I'm making a mention of it, where the placenta is found to be adherent. The C-section is performed, sometimes the C-section is performed in my center, or sometimes it's referred from outside, where the placenta has been kept behind. The placenta doesn't come out, and then it acts as not a complete placenta, parts of it, and it can really lead to very bad sepsis. One of your panelists mentioned that doing an MRI in a necessary situation, very important. I have seen in 2 or 3 of our cases, only sonography doesn't help. If at all you feel, step up, do an X-ray test, do an MRI, take a multi-team on board, and then we have also antimicrobial team which tells us about antibiotics and infections, which can be taken. We can have it as a group consultation, maybe, or if we have small practices, we can have experts catering to help us in that. Of course, anemia, diabetes, urinary tract infection, screening diligently during the antenatal period is extremely important. Teaching patients about perineal hygiene, wound hygiene, very, very important. And Muse chart at every place. At the time of admission, from transfer to labor room to the wards, from transfer to the labor room to the OT back outside, everywhere these Muse charts will really save women's life. And only even simple thing like after delivery, 48 hours, when you're doing the complete blood count, don't only look at the hemoglobin, but also start looking at the patient's WBC counts, and that will give us a lot of insight. Hematomas are always a source of infection, and breast has already been discussed. So I think this is my bit which I wanted to share with you, Kalyan. The 2 cases which I mentioned one was the placenta which remained behind. We were constantly thinking that she is having all that septic kind of, she was very fine for 5 days. For a baby, she was with us. And then suddenly she had hematemesis after about 12 days post-birth, and it was found that there was a massive duodenal ulcer, which also bled. We had to get the interventionalist to stop the bleeding, and the patient was quite bad. And finally, after 48 hours, I said that let's explore her inside. And this also was triggered by the fact that the same morning, baby's X-ray test was done, and it was found to be miliary tuberculosis. This was a patient who had conceived with infertility, twin gestation, one baby had died, and she was referred to us at the 36 hours post C-section. And then we found that it was actually a tuberculosis ulcer. What I want to tell you, my friends, is tuberculosis is there. It was such a bad infection. I myself have done dressings 3 times. I'm so grateful to the patient's relatives that they were supportive. We applied vacuum dressings to her, nearly about 14 in number. And you all know that vac dressings are extremely expensive. And then finally, now her wound is absolutely fine. They just met me about a month back, and they're absolutely fine. What I want to tell you, friends, is today, because of our antimicrobials, our good practices, we are seeing bad wounds, and therefore now we'll have to get into the action of learning to deal with these wounds, because in the past, women used to die. They used to never live, to show us those wounds, but today they are living, and therefore we all have to be well versed with these experiences. Thank you for giving me this opportunity, and it was wonderful listening to this panel. Kalyan.
Thank you so much, ma'am, for your insightful talk. Important is your experience talks a lot, because madam is a head of department and professor at Bharati Vidyapit Pune, and they are delivering mostly more than 50 patients a day. So experience speaks a lot, and it's really nice to listen from the stalwarts. Ma'am, you be there around at the end of the discussion. We'll have some cases where you can throw lights on the cases typically, ma'am. Now coming to again to the panel discussion, we were talking about the surviving sepsis campaign. Now coming to the very important, what is the septic bundle approach? So Dr. Puneet, are you there? I think Dr. Ankita can take this question. Dr. Ankita Borkar, she's a lecturer at Goa. Yes, doctor.
Yeah, so the Sepsis 6 campaign bundle that we say is basically in the golden hour, the first hour that you suspect sepsis, what you are expected to do. So one of the first things that you will need to do is you need to draw blood for blood culture, and it is important to administer antibiotics after having done that. Otherwise, your blood culture may not grow organisms. You need to start her on high flow oxygen and stabilize her with IV fluids. Then you need to start broad spectrum antibiotics after having drawn the blood. You also need to send serum lactate levels and monitor her urine output. So these are the components of sepsis 6. And I think in the latest 2024 RCOG guidelines also mentions about multidisciplinary care as one of the components as well.
Very rightly said. Sending a lactate level, remeasure if initial level is more than 2, obtain blood culture, broad spectrum antibiotics, start an hydration, that is very important. 30 milligram per kg in 1 hour for hypotension. Use of vasopressors if she is in hypotension. That is what is in a first hour expected to do. And take 3, that is culture, blood and urine. Give 3, that is IV fluids, antibiotics and oxygen, that is sepsis approach. And Dr. Girija madam has already talked about this topic about giving antimicrobial choices and their consideration. So Dr. Jigna ma'am, can you just elaborate about your use of antibiotics in your setup? Dr. Jigna Ganatra is there? Or
Yes,
Dr.
sir.
Yes,
Yes, sir. Yeah. Usually antimicrobial choices and its consideration, usually at the time of delivery, I give 1 dose of 3rd generation cephalosporin injectable, and then discharge the patient with 5 days of oral same 3rd generation cephalosporin. That is a usual practice. And usually before some time there was a campaign, and they had given us sir typical previous reports also that cesarean section requires single dose antibiotic. So we had given many of the patients single dose 2 gram cefazolin, and many all the patients were not having means clear cut cesarean sections without any risk factors. So single dose of 2 gram cefazolin was also sufficient in these patients. So because to prevent antibiotic resistance, that was the choice. But empirically, there is I would also like to know from others. So we had got a good result with single dose cefazolin 2 gram also without any further antibiotics. And those patients who are having high risk, we were giving cefaperazone sulbactam, and then usually 6 doses of cefaperazone sulbactam till the patient is in the hospital, and then we discharge with oral antibiotics. That's what my take is. And in many of the patients, I add metrogil also, and in some of the patients, gentamicin or amikacin also usually add, but that too after 8 hours of cesarean section. If patient is having severe sepsis, then we shift over to meropenem, gentamicin, clinda, metronidazole, and that depends. Sir, in our corporate hospital, we usually just now had a patient, but we went, she was already on meropenem, still was having, due to other risk factors, was having sepsis, CRP was high, PCT was high. So we had shifted her to xylistine also. And then at the end, after culture reports, she was on tigecycline and this polymyxin B. So usually usually the choice of antibiotic first we can start empirically. Then according to blood culture report, we can shift over to the other antibiotics, sir.
Thank you, Dr. Darshana Pandya. You want to add something? Dr. Darshana? Oh, Dr. Puneet? I think they are seeing the OPD in between. So for episiotomy, gram-positive amoxicillin, LSCS, then already has been talked about the amoxicillin, UTI, ciprofloxacin, severe sepsis, meropenem, genta, and toxic shock syndrome. You can add Clinda or gentamicin. Now coming to Dr. Ankita Borkar, what is the surgical management in the perineal wound?
In case of perineal wound infections, yes, if there is sepsis because of a perineal wound infection, then what we usually follow is prescribe antibiotics and IV antibiotics for a while, maybe 24 hours prior, and then consider a debridement first. If it's a perineal wound, then you can even consider sitz bath and cleaning and dressing till it looks fresh red, and then we can consider a suturing in a second sitting.
Yes, retained products of conception.
Yeah,
Less
for
than
retained
3
products of
centimeter, less than 3 centimeter.
again, yes, we do start antibiotics prior, and then maybe after 24 hours of antibiotic cover, that is when we consider the patient for evacuation.
Pelvic abscess more than 3 centimeter in the pouch of Douglas.
Yes, so again, it has to be drained. So sometimes it is accessible from the vagina. So colpotomy can also be done for drainage of an abscess or an under ultrasound guidance. And really, particularly when it is spread and causes peritonitis, then a laparotomy may also be indicated.
Cesarean wound dehiscence.
Cesarean wound dehiscence is similar to what we do for your perineal wound management, in the sense you follow the principle of initial dressing and antibiotic cover, then debridement, and at a later stage considering wound closure with
Right.
interrupted sutures or vacuum dressing.
And last resort hysterectomy in which cases?
Yes, when there is frank, purulent, infected uterus. So where there is abscess, micro abscesses in the uterus, for example, or there is rupture or perforation of the uterus, and where it is not salvageable, then, and it is a major source of sepsis. So that's when we may need to consider hysterectomy, and that is something that we need to counsel our patients about.
Have you seen any case of necrotizing fasciitis?
Yes, we have. In fact, I have seen a case of necrotizing fasciitis, which had extended towards the back and near the spine. So it involved the erector spinae muscle and the subcutaneous tissue there. So she had to be to undergo debridement and antibiotics, and at a later date we had to suture, and she also needed a graft in that area.
Very difficult to manage. You need to have good
Yes.
counseling. It might go to rectus sheath or
And
muscle.
you may need to involve surgeons as well in
Right.
such cases.
In such cases where it has gone to the myofasciitis, it is really difficult. Rehydration, wound scrubbing, maybe a 2 months time or sometime 3 months time also can be gone in only doing these dressings. So that is very important. So as to summarize, it causes death in 15% of the cases annually. The important thing for us, it can cause chronic problems like PID and infertility. So we have to be really careful about these cases. Now coming to Dr. Jigna madam, and last
Yes.
case Dr. Ankita will take. 28-year-old lady, PNC, para 2 living 2, FTND, home delivery, day 6, came with fever, high grade since 2 days, purulent vaginal discharge. How are you going to manage this case? Dr. Puneet Khatri, you need to be unmuting, please.
Yes, sir. If she is 28 year and there is typical history of home delivery, So if she comes with fever high grade since 2 days, then we definitely with purulent vaginal discharge. So I would like to on admission first clinically examine the patient, her vitals, and then per speculum examination, and simultaneously doing per speculum examination with if purulent vaginal discharge is there, then I would like to take vaginal discharge and send it for culture sensitivity. And regarding management, I would like to admit the patient, then give her starter with antibiotics after sending her all WBC and all the reports, and definitely antipyretics and supportive treatment with IV fluids also required. And if it is home delivery, then clinically I will examine the patient if any tear or any source of any this infection anywhere if we found in a local part, then would try to clean it everything, and then if tear is there, then would like to daily do dressing, and if wound is healthy, then and then we can take stitches at there.
Right. What if ultrasound is done and it is showing that the endometrial thickness is 20 millimeter? What next?
Sir, definitely only under ultrasound with endometrial thickness, we have to see vascularity. So, if vascularity is there, then it suggests that it is retained products. And if it is clear-cut hematoma, then I think, according to me, usually fluid inside the uterine cavity, minimal, or if clot is there, then no need to worry. That's what I clinically fit. But if it is showing vascularity, then after 24 to 48 hours of proper antibiotic coverage, I would like to do remove the product. Yes.
If vascularity is there, then only go for a suction, or you can go for a curettage for this. Dr. Darshana, you want to add something? You are listened to the answer given by Dr. Jigna.
And fresh blood transfusion. Sometimes it helps a lot. Fresh patient to improve patient vitality. Fresh the blood transfusion will improve the overall outcome, along with fluid, perfectly balanced fluid and electrolyte, parenteral fluid management, correct dose of antibiotic, correct dose, which sometimes we are forgetting, according to kidney function and patient blood body weight. We have to decide the dose of antibiotic and type of antibiotic according to culture and sensitivity. And debridement with dressing is very much important. And when we are doing septic wound debridement, then I prefer, along with hydrogen, this debridement with betadine and hydrogen peroxide, because it gives a recent oxygen to the tissue. And then the healing and this neovascularization is much better.
No, I want to ask Dr. Girija Wagh, madam, she's there. What is the role of blood transfusion even if HB is normal, madam?
I am telling you, not for HB, to improve improve her vitality. What I am giving is a fresh blood transfusion.
Okay.
Sir, now I'll tell you, Kalyan, the concept of giving fresh blood transfusion has completely gone now.
Yes,
because today we are only giving component therapy, and there are no such kind of evidences which are showing that you give a fresh blood transfusion, it will increase the wound healing. Anemia will get temporarily, only oxygen carrying capacity will increase temporarily, only for a period of few hours, maybe a 24 hours, when you are increasing her hemoglobin by giving packed cell volume. You can consider giving her PCVs or maybe
PCV, but
RBC
with
concentrates.
fresh transfusion. What I
Madam,
mean
it
to
is
say is
impossible
PCV with
to
not old transfusion.
No, but madam, it is impossible to get fresh transfusions because all the blood components are now processed. They have to be processed because without that the blood bank doesn't get accreditation.
Yes, madam. I am also, if hemoglobin
even I
is
feel that it is going to temporarily increase her oxygen carrying capacity. That is the only advantage. But if you are going to treat the source or remove the source,
Yes.
infection, that is more important than giving
Source treatment is very important. Absolutely.
right. Now coming to a very interesting case. This is a second case which has happened to my hospital, and this patient survived because of the multidisciplinary treatment. 34-year-old lady, primary gravidae 24 weeks, twins, IVF conception, home donation, BMI 17, came to OPD with bad smell around, with history of query leaking. Uterus was 30 weeks because of the twins. Both FHS were there. Per speculum foul-smelling discharge. She was 1 centimeter open os. Membranes were absent. No liquor demonstrated. That means AFI 0. Ultrasound suggestive of live twins. 650 and 700 grams. AFI 0. WBC count was 20,000. Platelet was 80,000. HbO has dropped to 8 gram%. Patient not ready for delivery. Now coming to Dr. Jigna. If such patient who is into chorioamnionitis and not willing, how you manage such patients?
Sir, definitely whenever a patient comes, it is to anticipate, to see, and then proper counseling of the patient's relatives and documentation of whatever our findings, and if they are not willing, whatever advices we give and taking their signature is very important as far as concerned. And regarding management, if such patient comes, then first we have to send all blood reports, and we have to start high dose antibiotics, because this patient is WBC count of 20,000, platelets have also dropped, and HB is 8. Then definitely, and there is history of leaking is also there, and pregnancy is 24 weeks. If they are not ready for delivery, then we have to explain them all the consequences if they continue. And definitely whatever we can give is proper monitoring of this patient, and we can give her supportive treatment in the form of higher antibiotics and supportive treatment, antipyretics and supportive treatment, sir.
Okay, Dr. Jigna, I counsel this patient.
24 weeks pregnancy is there, then after giving antibiotics, steroid तो सर दे देने का है, but antibiotics के 2 डोज जाए, बाद में तो steroid दे सकते हैं, because balance तो करना है ना सर इसमें.
Okay,
Fetal.
I tried to counsel this patient, and I told you are in a frank sepsis and chorioamnionitis, and now you need to deliver at any cost. So now they were behind me to do a cesarean section because they wanted these both babies to survive. Now, Dr. Puneet Khatri, what is the irony and what is the difficulty in doing cesarean section with such frank sepsis?
Yes, there is leaking. Leaking is there is a bad smell around, so leaking might be quite long period of time.
Yeah, that was
there is
very important.
Patient is highly likely. Patient is likely to go into septicemia. Definitely, she might be in septicemia already right now also. So during cesarean, first of all, we need to cover her by antibiotic cover before at least 12 to 24 hours, like higher antibiotic like piperacillin, tazobactam, or meropenem or colistin, whatever.
Puneet bhai, my concern was different. Platelet was 80,000. I don't know since how long it was. CRP was high. So I told them I can't do a cesarean for you.
Okay.
We did a induction, pitocin.
Okay.
She delivered only in 4 hours. Now see the consequences. Her platelet dropped down to 40,000 at the end of delivery. She had hypoxia. We shifted to ICU after 2 hours of the delivery, where she was on ventilator for 8 days. And then she came out after 9th day. Then in this case, if I would have done a cesarean section, what was my fate and what relatives must have done? Because so many times it's a precious pregnancy, they feel removing the baby and giving to NICU is very important in such cases. But you have to be really judicious enough to decide the route of the delivery, Also, if a cesarean has to be done, it has to be done extra peritoneal cesarean section if required. So now we are coming to our expert, Dr. Girija Wag, madam, for her management protocol for such high-risk chorioamniotic septic patients.
Yeah, your idea of doing a C-section, doing an induction was a very good concept because she had thrombocytopenia, which can also be a presentation of a sepsis, wherein because there is always a microangiopathy which is associated where the platelets get consumed, and these are the patients who are quickly going to go into DIC. I would have rather taken this patient to a tertiary care center at the outset only, and the moment she delivered, put her into an ICU. But then you were very lucky and you did it because you were constantly, conscientiously looking at her, and therefore you could immediately take that decision and the patient got saved. But
So
such
now-
patients can very easily die because
Yeah.
of the hypoxic brain damage. They can simply succumb. And therefore, we have to be very careful. But that was a very good decision, very wise decision. If you're done C-section, Bapre, she would have gone into definitely a
On
septic
the
shock.
table
Maybe
itself, yeah.
on the table itself, you could have lost her.
So take-home message from such high-risk cases is first, shift to multidisciplinary setup. The thing
Yes.
which I was lucky that after 2 hours she deteriorated. I
Yeah.
had time to shift her. Second thing is very important. Don't get carried away with the relatives' request of doing cesarean for saving such babies because it was a IVF conception. And thirdly, these patients who are lying to you about the history and everything, please assess this patient in a proper way, manage with a physician or with the ICU backup, and then only you can manage such patients. So many times it is not, or it is very important to say, please, we will go together to a multi-specialty hospital.
Absolutely. Because
hospital.
it may sometimes be said by the community that doctor na kuch risk nahi lete. It's okay, it doesn't matter. Let's not get egoistic about it. It's okay, we don't want to take risks and we don't want to allow you to die. But we have to be wiser.
Right, such patients will give you a lifetime experience of how to go about not doing heroics alone. Please involve another gynecologist, please involve ICU consultants and specialists so that you don't go into a soup managing such patients, because the mortality rate is around 30% in such patients. So it's very important to counsel this patient properly, counsel the relatives, and deliver this patient in a multidisciplinary setup or ICU setup. Dr. Girija ma'am, last words for...
Dr. Jigna mentioned something very vital and important.
Yes,
and
ma'am.
that is so very important that you must document everything. Today, we have started a practice of not only speaking to the patients, but we speak in the presence of relatives as well as the staff nurses.
Video
Our
counsel.
own ward coordinators, not video consultations only in high-risk patients, but otherwise we write and document everything that is possible there, because it's so important that they sign and they have understood everything. Secondly, many times when you are referring patients to tertiary care centers, please write everything. That Muse chart is very easy to fill. Give it, because many times practitioners don't send the reports to the referring center. Even in Pune, it's happening. It's very important that we write everything that has happened there, or at least share it with your doctor. And today we have ways of documenting things. You can take just simple pictures, label them. You can put, you can do geotagging. Geotag karke pictures le sakte ho for evidences that this is that patient's picture. So we can use all these kind of apps which are there to help us, save us, because these documents are very important. When everything goes well, patients forget everything, but everything goes wrong, then they will completely blame you. And I have seen many times morning rounds which I take with our patients. I said, why did you go in for maternal request C-section, by the way? You were delivering. My doctor said, no, madam, there was thin meconium. I didn't want to take a risk. I said, you would have delivered. And then some relative will say, no, doctor ही बोले कि हम risk नहीं ले सकते. Like they will, twist your words. So therefore, always document things correctly. We are Unfortunately, we are living with a community where everywhere, I think in all populations, it's so that people have to pass on the blame to somebody else. We are constantly trying to find things. ये किसके वजह से हुआ या किसने किया? So therefore, we have to be very smart about it.
Yes, very rightly said, ma'am. So, Madam Ji, yes, Dr.
Hello, sorry to interrupt you. Hello.
Yes,
Dr. Kalyan, sir. Hello.
Yes, sir.
Yes, in this patient, you induced the patient and she delivered within 2 hours or 4 hours. If the induction delivery interval you anticipated is more than 12 hours or 24 hours or 48 hours, then what you should have been done? If your anticipated induction delivery interval is more than 12 hours, what should be the ideal management?
Sir,
is the management going to change or will remain the same? Am I audible?
Yes, sir. Yes, sir.
Am I audible?
More than 12 hours in such high-risk patients.
Hello?
Because you are sitting on a bomb where platelet count is dropping, the patient's AFI is 0, there is a foul-smelling discharge.
No, what I want to ask, between the network, there's some network problem.
Sir.
In between, your voice is interruptedly coming. You're not audible properly. Am I audible to you?
Yes, sir. Now you are audible.
Am I audible? Now, okay. So what I want to ask you should have you did induction and delivered in 2 hours or 4 hours. So if the induction, your anticipated induction delivery time is more than 12 hours or 24 hours, then would you have been kept the infected focus inside or you should have taken it out by LSCS?
So this was twins. OS was open. That is the reason I went for a induction by vaginal delivery. Otherwise, I have shifted this patient to a ICU and did a extra peritoneal cesarean section.
Perfect.
Because if OS is tubular, close, I will never do such heroics because that septic focus is inside. Already the leaking amnion is broken. The infection is gone to the uterus. So it's very important for such patients.
Yeah. Okay. Thank you.
You were very lucky she didn't went into PPH and all that, okay? By the way, Pyometra.
Yes. So now,
with
Dr.
leaking,
Jigna.
I would like, usually with leaking and with whichever high risk patients, the progress is fast as compared to other patients.
Other
They
patients,
should-
right? Because body also wants to throw away this infective focus. Yeah. Dr. Darshana, you want to add something? We are closing up. Dr. Darshana Pandey has given a lot of good inputs from Rajkot. Dr. Darshana, ma'am.
I'm sorry, sir.
The OPD in between.
I have to handle OPD in between also, but it was actually a very enlightening experience from the all dignitaries across the India. And we have learned so many things. In these days, to know about sepsis, actually it should not be there.
Yeah.
But
Kalyan,
once
can
it
you
is
say
there,
something?
once it is there, then we have to be extra vigilant and everything we have to treat as a multidisciplinary approach. Because then once it is advanced, then it is multi-organ involvement and time is the money in such cases.
Yes,
and
thank
team
you,
approach,
Doctor.
as Madam said, this
Yes.
team approach and extra vigilance on part of clinician.
Yes, thank you,
And,
Dr. Darshana,
I
ma'am.
would,
Now coming to Dr. Girija Wagh, madam, for final remarks.
I'm sorry, these are not final remarks. I'm taking disadvantage and the privilege of your being
No,
expert
last
on
2
the
minutes
panel.
are remaining. Yeah.
So,
8 o'clock.
Gestosis India Association is organizing the World Organization Gestosis in May. So, May 16, 17, all of you are invited to Pune. Please mark your calendars. I'll put a post in the group with your permission, Kalyan.
Yes,
Okay?
ma'am. Please.
Yeah.
Please.
Thank you.
Yes,
The
Dr.
inputs of
Jigna.
Madam was excellent, Madam.
Madam is such a wonderful person and she guides all the gynecologists whenever you give her call. She's always there for you.
All
She will
time, ma'am.
guide.
All time medicine.
And
I'm on ATM.
biliary
It-
tuberculosis, actually, these days
She's
we
the
are
ATM
forgetting
for us.
tuberculosis.
She's the ATM for all Maharashtra.
Yes, madam. Before 2 years, same way you came to Rajkot. Yes,
Ah,
madam.
Adhika, I'm so
Yes,
happy to see that you are doing high risk obstetrics. You remember you had said, Madam, I want to do high risk. And I'm really
Yes,
proud of
madam.
you. You are doing it.
Yes, madam. Yes, madam.
Yes. So at the outset, I'd like to thank our expert, Dr. Girija Wagh, madam, Dr. Darshana Pandya, ma'am from Rajkot, Dr. Karthikeya Shastri from Rajkot, Dr. Ankita Borkar from Goa, Dr. Jigna Ganatra, Dr. Puneet Khatri, and our two people from our team, Dr. Monica Umbardand and Dr. Monica Gupta, and Team Corona for this wonderful initiative that is Eco Webinar Series. Over to Dr. Monica for vote of thanks.
I want to appreciate Monica. Thank you so much for such seamless organization and hosting.
Thank you, ma'am. Thank you, Dr. Kalyan sir, for the opportunity to coordinate the ECO webinar series. This is the 11th episode, and we would like to thank Dr. Suchitra Pandit madam, Dr. Sujata Dalvi, and Dr. Lakshmi Srikhande madam for joining us for the inauguration. Our speaker, Dr. Atul Ganatra sir, who presented wonderfully on heart disease and pregnancy. Our chairpersons, Dr. Pinky Kataria, Dr. Darshan Sureja, and Dr. Dharmesh Patel. The panel discussion on puerperal sepsis was excellently moderated by Dr. Kalyan Baramde sir and Girija ma'am. Thank you so much for all your expert inputs. The delegates must have had a lot of take-home messages. Our panelists, Dr. Ramanlal sir, Dr. Puneet Khatri, Dr. Jigna Ganatra, Dr. Ankita, Dr. Sunil sir, Dr. Gaurav Gadvi, Dr. Karthik Shastri, and Dr. Darshana Pandya. Thank you so much, Team Corona, for the academic platform. And see you after 15 days for the North Zone webinar.
Thank you so much.
I would also like to appeal to all the adjoining societies to help Dr. Kalyan Baramde sir in his candidature for West Zone President, Vice President Foxy.
We know,
Sir,
sir,
wishing-
since long, and sir, it is fixed, and we advancely congratulate you, sir. Your work
Thank
is
you,
like
Dr.
that.
Jigna ma'am. And we have Dr. Sujata Dalvi ma'am who has joined us now.
Yes.
So,
Yes,
madam,
madam.
welcome. We are just about to finish it.
I know, Kalyan. And then I WhatsApp Monica and she said you can at least join it in the end.
So
We had
nice to
emojis
at least
meeting
here,
and some Jogi meeting, this and that. But anyway, I heard everybody wishing you best wishes for your future endeavor in Foxy. So from my side also, best wishes to you. And congratulations for having this eco webinar. And of course, credit not only goes to you, but the conveners, two Monikas and one Shatabdi Day.
Shatabdi Day, yeah.
Yes, correct. And of course, I'm sure the panel discussion must have been very meaningful and talked by even
Dr.
Atul Ganatra. Atul Ganatra also must have been very good on heart disease in pregnancy. But anyway, next time I'll make it a point to join as
Next
far as
West Zone
possible.
webinar will
Yes.
involve you once again,
Yes,
ma'am. Thank
definitely.
you so
No
much.
problem. Thank you so much.
Thank you,
And best
everyone.
wishes.
Good night.
Best.
Thank you for
Yes.
all the blessings. Thank you.
Thanks. Okay.
Thank
bye.
you so much, everybody, for wonderful, insightful session. Looking forward to conduct such more sessions with you. Thank you so much on behalf of Corona Remedies. Thank you
Thank
so
you,
much.
Team Corona. Thank you.
Thanks.
Thank
Bye.
you. Thank you, everyone. Thank you.
Bye.
Everybody,
Good
bye
night.
bye.
Bye, ma'am. Happy Holi in advance. Thank you.
Same to you all.